on we have a seminar on achalasia cardia. We have 3 speakers: Dr. Swarup Satra from RKM, Dr. Rayan from Imambara Hospital, and Dr. Hari Prasad from Salvation Hospital. So we'll start with the first presenter, and today Dr. S.M. Bhattacharya is a professor, head of surgery at VIMS.
Seminar.
Okay. So, Dr. Swarup, you can start.
Thank you, sir. So,
good morning. Yeah, good morning.
Good morning, respected teachers. Today I'll discuss on the physiology and physiology of esophagus and some esophageal, the classification of the esophageal motility disorders. To start with the physiology of esophagus, at first we'll go through the basic anatomies for a while. This esophagus is a 25 centimeter long tubular structure, which comprises of 4 layers as gastrointestinal, all the other gastrointestinal tract except for the adventitia in the place of serosa, and the muscular layer comprises of striated muscles and smooth muscles with a mixture in the middle part of the esophagus. And the nervous, the neural supply is the parasympathetic and sympathetic, comprises of parasympathetic and sympathetic system. The parasympathetic, which is the sensory motor and secretomotor part, which is mainly supplied by the vagus nerve. The upper half, or mainly the skeletal half, is supplied from the nucleus ambiguous by the recurrent laryngeal nerve, and the lower half, or the mainly the smooth part, smooth muscle part, is supplied by the dorsal nucleus of the vagus. And next, there is an enteric nervous system present in the GIT, which comprises of the 2 plexuses. The first one is Auerbach plexus or Myenteric plexus, which is situated between the outer longitudinal and inner circular muscle layer, and the Meissner or submucosal plexus, which is present in the submucosa. And as I told earlier, that the vagus, the dorsal motor nucleus, which mainly supplies the smooth muscle part or the lower part of the esophagus, and the nucleus ambiguous, which supplies the upper part or the striated muscle part of the esophagus. The main functions of the esophagus are the deglutition or swallowing, or the passage of food from the oral cavity to the stomach, and secretions from the submucosal mucous glands, and protecting the esophagus from the reflux or some other hazardous elements. The sphincters at both the end have resting tone, with which prevents air, solid or fluid from passing out in or out in the resting condition. There is no enzymatic secretion or digestive activity of the esophagus, and there is no absorptive activity of esophagus. So the swallowing or deglutition, it mainly comprises of mainly takes the 10 to 12 seconds. The whole process, it's a complex process and requires a number of important features to change the pathway of breathing of air in between the mouth, nose, pharynx, and the trachea into the channel for passing liquid and solid further into the esophagus. The anatomic relations functionally change during swallowing, especially as the upper esophageal sphincter is not a complete one. It moves upward approx 1 centimeter because of the laryngeal upward swing. The swallowing or deglutition, it has mainly 3 phases: oral, pharyngeal, and esophageal, out of which the oral phase is the voluntary one and the other 2 are involuntary ones. In the oral phase, and the tongue and the surrounding structures of pharynx, soft and hard palate, and the closed glossopalatal area forms the bolus. Just before the oral phase starts, there is a preparatory position in which the bolus is placed over the posterior dorsal surface of tongue. And then the first step is performed by the soft palate and the posterior aspect of the tongue, and the next step is the upward movement of the soft palate towards the hard palate, closing the nasopharynx, and upward swing of the hyoid bone more ventrally. And when the tongue creates more pressure, it goes to the next phase, that is the involuntary pharyngeal phase. The most important part of this phase is a well-coordinated closure of the airway during the passage of bolus. The bolus enters the pharynx, it stimulates the epithelial swallowing receptor areas all over the pharynx, and impulses passes to brainstem. And then as there are few openings through which the food may go, it can come back to the mouth, it can go upwards into the nasopharynx, it can go forward in the respiratory system, in the larynx. All those are prevented by different mechanisms. In the larynx, it's just like in the larynx, it's prevented by the approximation of the vocal cords and forward and upward movement of the larynx, backward movement of the epiglottis to seal the opening of larynx. All these movements arrest the respiration for a few seconds, which is known as the temporary deglutition or swallowing apnea. It is mainly controlled by the glossopharyngeal and vagus nerve. The food particles in this way the food particles are prevented from going into the mouth or nasopharynx or larynx and forced to the into the esophagus. In the next comes the esophageal phase, which is also an involuntary one. In this phase, mainly the peristalsis, primary and secondary peristalsis comes in. The primary peristalsis starts with the swallowing, and it is mainly controlled by the swallowing center in the medulla oblongata. It travels at a speed of 3 to 4 centimeter and reaches amplitude of 60 to 140 millimeter of Hg in the distal esophagus. And secondary one is to clear out the remaining retained bolus or remaining materials or reflex materials in the esophagus, by which the primary peristalsis has failed to clear. The tertiary peristalsis also present, that is abnormal, non-propulsive and uncoordinated, basically seen in elderly people, and when it doesn't follow the peristaltic nature, that means they move the bolus up and down in both the ways. This involuntary part of the swallowing, that is the pharyngeal and esophageal phase, is basically controlled by the deglutition reflex, and this afferent one is controlled by the oropharyngeal receptor, by the cranial nerve, glossopharyngeal nerve, and efferent one by glossopharyngeal and vagus both. The reflex causes upward movement of the soft palate to close the nasopharynx and upward movement of larynx to close respiratory passage. The peristalsis starts in this way. The two important sphincters are present in the upper part of the esophagus and the lower part of the esophagus, which helps in the act of swallowing and the preventing the esophageal reflux. The upper esophageal sphincter, it has a higher resting tone than comparative to lower esophageal sphincter, and there is another important landmark, that is gastroesophageal junction, which is histologically the point where there is no longer any submucosal esophageal glands or the proximal extent of the gastric oxygen gland. Endoscopically, the junction has been defined as the squamo-columnar junction or Z line, the proximal extent of the gastric mucosal folds. Surgically, it has been defined as the junction as where the peritoneal reflection on the stomach and the junction of the tubular esophagus and the stomach. In person with ileus damage with the symptoms of GERD present or not, the true gastroesophageal junction is separated from the endoscopic gastroesophageal junction by cardiac epithelium with or without parietal and or goblet cells. So, yes, now the esophageal motility disorders. Esophageal motility disorder can be classified based on the etiology, based on involvement of the esophageal part or area which is involved, and based on manometry. Based on etiology, it can be classified as primary or secondary. The primary examples are achalasia cardia, diffuse esophageal spasm, nutcracker or Jacquemin esophagus, hypertensive lower esophageal sphincter, and ineffective esophageal motility. Secondary can be due to different secondary causes, most commonly scleroderma, then Case syndrome, dermatomyositis, polymyositis, lupus erythematosus, Chagas disease, myasthenia gravis, alcohol consumption, diabetes, hypothyroidism, Parkinsonism, stroke, severe esophagitis, vasculitis, etc. Based on involvement of esophageal areas, when upper esophageal involvement, like upper esophageal disorders, sphincter disorders, neuromuscular disorders. When the body is involved, it may be a diffuse esophageal spasm or distal esophageal spasm, nutcracker esophagus or hypercontractile esophagus. When body and lower esophageal sphincter both are involved, achalasia cardia and ineffective esophageal motility, and lower esophageal sphincter is involved is hypertensive ileus. Now, based on manometry, there is the esophageal motility disorder is classified by the Chicago classification. There is a best classification of for esophageal motility disorder, Subsequently applied to interpret the manometric findings and to facilitate a diagnosis of esophageal motility disorders. First, it was the first classification came on 2008. Then it was modified on 11, 14, and recently on 2020. Derived from the data obtained by HRM and EPT. HRM is a high resolution manometry, that is a transnasal passage of catheter with pressure sensors into the esophagus. 10 wet swallows of 5 ml water each are given in the supine position. The pressure sensors are no more than 1 centimeter apart. In the conventional manometry, it was 3 to 5 centimeter apart. So over here, the number of sensors were approximately 36. And during each swallow, the followings are evaluated. Those are esophageal gastric junction relaxation, esophageal contractile activity, esophageal pressurization. And this whole resolution, this manometry, when it is depicted in a graphical representation, it is called as esophageal pressure topography or EPT. This is like EPT, where we can see the upper esophageal sphincter with higher resting pressure, and over here the lower esophageal sphincter, and this x-axis is the esophageal length, and over here this is time. When the contraction starts, the peristalsis comes from the pharynx to the proximal esophagus. Then this is the transition zone in between the proximal and middle esophagus. That is the from striated muscle to the smooth muscle zone. This transition zone is usually less than 5 centimeter, and then this closet segments of the contraction goes, and over here the lower esophageal sphincter and the pleural diaphragm or the diaphragmatic opening pressure is depicted over here. There are main 4 parameters which we should know for this manometric reading. These are IRP or integrated relaxation pressure, the distal contractile integral or DCI, contractile deceleration point or CDP, and distal latency or DL. This IRP is relaxation pressure after 4 seconds of swallowing in the distal sphincter. That is basically the assessment of EJG relaxation. It's a mean of the 4 seconds of maximal deglutitive relaxation in the 10-second window beginning at the UES relaxation reference to the gastric pressure. That is normally it is 15 millimeter of Hg, less than 15 millimeter of Hg. Now the DCI or distal contractile integral, it describes the vigor or strength of distal esophageal contraction measured as the volume of the esophageal contraction spanning from the transition zone to esophageal gastric junction. It is the unit is amplitude into duration into length, that is millimeter Hg second centimeter. It ranges, the normal range is 450 to 8000. If it is less than 450, it is ineffective. 100 to 4, in which 100 to 400 is depicted as weak, and less than 100 is failed peristalsis, as minimum 100 is required for the peristalsis to start. And if it is more than 8000, then it is hypercontractile. CDP is the it reflects the inflection point in the contractile front propagation velocity, or where the velocity of the persistent pressure wave begins to slow as it approaches the esophageal gastric junction. It is a landmark used to calculate the DL or distal latency. Interval between upper esophageal sphincter relaxation or onset of swallow and CDP is considered as an important metric indicating the integrity of the inhibitory pathway in the distal esophagus. It is basically the assessment of presence of premature esophageal contractions. If the value is less than 4.5 seconds, the premature contraction or spasm is present. And if it is more than 4.5 centimeter, then it is normal. Here are some graphical presentations of EPT of some normal and abnormal features. It's like esophageal gastric junction, which can be classified, which can be of 3 types, basically type 1, type 2, and type 3. When the lower esophageal sphincter and pleural diaphragm overlaps each other, then it is normal. This is the picture. And type 2, where the pleural diaphragm and lower esophageal sphincter aparts, and it's less than 2 centimeter. And in case of, just like in case of hiatus hernia or in some others, where the lower esophageal sphincter gives another pressure zone, and the pleural diaphragm gives the another zone. this gap is more than 2 centimeter. This type 3 esophageal gastric junction. Some normal, ineffective, fragmented, absent esophageal contractions are also shown here. Now the Chicago classification of esophageal motility type 3, version 3. In third version of Chicago classification, it has been classified as three major groups: this achalasia and EGJ outflow obstruction, the major disorders of peristalsis and the minor disorders of peristalsis. If the median IRP is measured, if it is more than 15 mm Hg, then it goes to the achalasia and esophagogastric junction outflow obstruction. Just like type 1 achalasia, that is a hypomotility disorder, this classic one in which the median IRP is more than 15, 100% failed peristalsis, that is DCI is less than 100, and premature contractions with DCI less than 450 criteria satisfy the criteria for failed peristalsis. Type 2 or the esophageal compression, that is again the median IRP is more than 15, 100% failed peristalsis with pan-esophageal pressurization. Type 3, there is the spastic type in which no normal peristalsis were present. The spastic contraction is present in more than 20% of the swallows. And if there is all those three criteria, if all the three criteria are not met with the median IRP more than 15 mm Hg, then it is called as EGJ outlet obstruction or achalasia in evolution. If the IRP is normal and there is 100% failed peristalsis, then it is absent contractility. If the IRP is normal and the more than 20% premature contractions with DCI more than 450 is, then it is distal esophageal spasm, which is previously called as diffuse, which is also known as diffuse esophageal spasm. And at least 2 swallows with hypercontractile nature, that is DCI more than 8,000, it is called as hypercontractile esophagus or nutcracker or jackhammer esophagus. And if if those criteria are not met, it comes into the minor disorders of peristalsis, in which more than 50% ineffective swallows or fragmented contraction is noted. And here are some pictures. This is type 1, type 2, and type 3 type of achalasias with the manometric HRM high resolution manometries and barium swallows. And the recently classified the recent version of the Chicago, that is Chicago 4, in which the division has been changed from disorders with EGJ outflow obstruction, major and minor classifications to disorders of esophagogastric junction outflow and disorders of peristalsis. Again, the same thing. The major changes present here are where the high resolution manometry was done only in the primary position or in the supine position. Here, primary and secondary or sitting position is also done. And here some others terms are also included, like MRS, that is multiple rapid swallow, and RDC or rapid drink challenge. When the first 10 wet swallows of 5 ml is done, if the IRP is abnormal or more than 15, it goes into achalasia version, that is achalasia type 1, type 2, type 3, again with 100% failed peristalsis, and achalasia 1, 100% failed peristalsis with pan-esophageal pressurization in more than 20% swallows is achalasia 2, and premature contractions, that is achalasia 3. And if there is this high IRP not absent or peristalsis is present, then we will go for the secondary or sitting position of MRP, in which elevated LES IRP if the IRP is elevated or IVP and pan-esophageal pressurization is present, then and we go for TB or flip. TB is timed barium esophagogram. If it is abnormal, then it will that is diagnosed as
Saurabh, you conclude, Saurabh.
Yes,
Already
sir.
20 minutes. You conclude.
Oh, sir. Sir, these are the just terms that multiple rapid swallow, rapid drink challenge, timed William esophagogram, and functional lumen imaging planimetry. And this is the pictures with 10 wet swallows and multiple rapid swallow, along with the supine and upright position changes in manometry. So the major changes, I'll say these major changes and conclude. The first is the manometric and non-manometric evaluation is required to arrive at a conclusive actionable diagnosis of EGJ outflow obstruction. This diffuse esophageal spasm, EGJO, and hypercontractile esophagus are the manometric patterns that must be accompanied by obstructive esophageal symptoms of dysphagia and or non-cardiac chest pain to be considered clinically relevant. The third, the standardized manometric protocol should be ideally include supine and upright positions as well as additional manometric maneuvers such as the multiple rapid swallows and rapid drink challenge, solid test swallows, postprandial testing, and pharmacological provocation. And the definition of ineffective esophageal motility is more stringent and now encompasses fragmented peristalsis. And this fourth version no longer distinguishes between major versus minor motility disorders, and it simply separates disorders of EGJ output from disorders of peristalsis. Thank you, sir.
Okay, Dr. Bhattacharya. Dr. Bhattacharya, any comment? Saurabh, you have given the good description of the anatomy, but you should have mentioned the sites of normal esophageal constrictions. There are normal sites of constriction, like
Yes,
the at the esophageal pharyngeal junction, crossing of aorta, crossing of bronchus, and the UG junction. Okay, so these are the normal sites of constrictions.
yes, sir. So actually, I didn't explain. I have given all those four constrictions, but I haven't told, sir.
Yeah.
Actually, you have given in the picture, but thing is that
Yes.
you have elaborated so many things. Okay, so it is
Yes,
I think it is more elaborate. Okay, so it doesn't require actually up to master degree level, I think. Yeah, but you have given nicely presentation. It is nice presentation. You have elaborated it. Okay, thank you.
Thank you,
I
sir.
think that we should pass on to the next speaker.
Yeah, Dr.
Thank you,
Revant,
sir.
you will speak on etiopathology of achalasia cardia. Revant, you share your screen. Revant, you start. We can see your screen.
Hello.
Revant, you are not audible. Yeah.
Can Revant please be unmuted? Revant is on
Sir,
mute.
sir, I am sending him request, but he is not taking that.
Hello, am I audible now?
Yeah,
Yes,
yeah,
you are
yeah.
audible now.
Now,
Okay,
now
okay,
you
sir.
are audible.
Okay, sir. Okay, good morning, everybody. Myself, Dr. Raven from Imambara District Hospital, and my topic of discussion is eclasia cardia, its etiology and pathology. The literal meaning of the term eclasia is failure to relax. It is one of the best understood of all the esophageal motility disorder. The incidence is 6 per 100,000 persons per year, with a predilection to affect young women. It is due to the basic pathologies. It is due to loss of ganglion cells in the mindrick / Auerbach plexus. Etiology, there are two types of etiology: primary and secondary eclasia. In primary eclasia, there is a loss of intrinsic inhibitory innervation of the lower esophageal sphincter and smooth muscle segment of the esophageal body. Secondary eclasia, it arises from pathologic process that impair the esophageal functions, such as Chagas disease, caused by Trypanosoma cruzi, which causes destruction of the mindrick plexus of the esophagus, duodenum, colon, and ureter. Disorders of the dorsal motor nucleus, such as polio and autonomic neuropathy in diabetes, severe emotional stress, trauma, and drastic weight reduction. Pathology, the destruction of the nerves to the LES is the primary pathologic process, and the degeneration of the neuromuscular function of the body of the esophagus is secondary. The classic physiological abnormalities are non-relaxing lower esophageal segment and absent peristalsis in the body of esophagus. The Chicago classification identifies 3 variations. Although most patients have almost no recognizable contraction, that is type 1, some patients continue to exhibit pressurization through the esophagus, type 2, whereas in others, esophagus is of normal caliber and exhibit high pressure contractile, non-peristaltic activities, such as spastic esophagus and vigorous eclasia. High resolution manometry recognizes these contractions, important for predicting the outcome of the treatment. With time, esophagus dilates and contraction disappears, so it empties by hydrostatic pressure of its contents. The megaesophagus becomes tortuous with persistent retention esophagitis due to fermentation of food residues, and this may account for increased incidence of carcinoma of esophagus. Squamous cell carcinoma is the most common type identified. If the histology is adenocarcinoma, it tends to appear in the middle third of the esophagus, below the air fluid level, where the mucosal irritation is the greatest. This is the Chicago classification, the 3 types. In first type, you can see the integrated relaxation pressure is high, and peristalsis is absent, and contractile activity is also absent. In type 2, the IRP is normal, peristalsis is absent, contractility is also absent, and the resolution of pressure is occurring. In type 3, the IRP is high, peristalsis is absent, 2 or more spastic contraction with or without periods of compartmentalization pressure is present. Thank you. Hello. Hello.
Hello.
Hello. Sir, my presentation is over.
Yeah. So this is the etiology. So basically, basically 2 types. It is the primary and the secondary.
Yes.
Yes.
Sir.
The most of the cases, what we can see in the eclasia, it is the primary.
Primary, sir, autoimmune.
Okay. So in the primary, so you have classified it again, type 1, type 2, and the type 3.
Yes, sir.
Of which one is very common?
So type 1 is most common, sir.
Most common. So how, besides manometry, is there any other investigation by which we can assess that one?
Sir, this endoscopic.
But ideally, the manometry is the key thing.
Yes,
is
sir.
It?
Yes, sir. Gold standard is manometry only.
Okay. But
sir,
to diagnose,
barium meal is also there if manometry is not available.
Yes. As because that is the thing, that's because the manometry is not available in each and every center, then this one can happen. Okay. Or the lateral. Hello.
Yes, sir. Hello.
Hello.
Yes, sir. I'm able to hear you, sir.
Yeah. If you do the X-ray chest, normally most of the cases it has been seen the fundic gas is not present. So that
Yes,
is
sir. The
another
fundic gas
thing.
is not present. Yes, sir.
Yes, and straight X-ray, if you do, you will see there is the fluid level, okay, in the esophagus and a fluid
Yes, sir.
level.
Yes, sir. Yes,
So
fluid
these
available.
are the things. So you must have to discuss, as because you have discussed here, the ES manometry is the key thing. But even then, what are the available investigations available? So you must discuss that one. Okay.
Yes.
Okay. Okay. I think so. Makunda, any comment or any? Hello. So we should go for the next one for the management purpose. Okay.
Hello. Hello.
Yeah.
Sir, good morning to one and all.
Yeah.
I'm Dr. Hari Prasad, second year PGT from Southeastern Railway. So today I'm going to discuss about the clinical features and management of achalasia cardia. Hello. Hello. Hello.
Carry on, please.
So
Carry on, please.
introduction. Esophageal motility disorders should have the features of dysphagia, non-cardiac chest pain, and structural abnormalities should be excluded, and eosinophilic esophagitis should be ruled out. These are the prerequisites for considering a disease as esophageal motility disorder. So achalasia cardia, as it refers to in Greek as akalon, failing to relax. So it was recognized in 1600. Just for a history, so people used to think it as a cardiospasm because of the severe chest pain, and it will be treated with self-dilatation with whale rib. So this is a whale rib, so they will use it for dilatation purpose. The dilatation what we are using now, they are followed in the 16th century itself. So epidemiology, as already discussed, the incidence rate is around 0.5 to 1.2% per 1 lakh population. There are a lot of disputes between the female preponderance, but the Shackelford latest edition has mentioned the male and female incidents are mostly same, and it affects all the age groups. And etiology is unclear. So there are autoimmune, viral, neurodegenerative factors like absence of mindric plexus. So the symptoms, the classic triad, as we usually say, it's the progressive dysphagia. Initially, it will be starting with the liquids and then progress to solids, and the postprandial regurgitation of undigested foods, and nocturnal cough, and the aspiration. The most common presenting symptom used to be the progressive dysphagia. Almost 90% of the patients used to have progressive dysphagia. So this is the ICARD scoring. Considering the level of achalasia, it involves the weight loss, dysphagia, and post-sternal pain and regurgitation. So you usually categorize according to the parameters like the weight loss 5 to 10 kg or less than 5 kg, more than 10 kg, whether the dysphagia or post-sternal pain or regurgitation is occasional or it is happening daily, at least one meal a day, or it is happening with each meal a day. So the approach, always if we suggest that the patient is having an achalasia cardia or any motility disorders, the approach is used to be the best investigation will be the esophageal manometry. But to start with, we should always start with the upper GI endoscopy to rule out any mechanical obstruction. If there is any mechanical obstruction at the lower esophageal junction, due to that also we can get a secondary achalasia cardia. So always it is wise to start with the upper GI endoscopy. So this is the barium swallow. It's a radiological investigation where we can find the dilated esophagus with a tight bird beak lower esophageal sphincter due to the high lower esophageal sphincter pressure. And these are the types you can see. There's mostly the straight type, which is an early type. And when it is dilated, it is called mega esophagus or a sigmoid type of esophagus. So you can see the pictures over here. And another advancement in the esophagogram is time barium esophagogram, where we use 100 to 200 ml of low density barium sulfate, which is 0.45%. It is given to the patient in upright position. Radiographs are obtained at 0, 1st, and 5th minute. This discrepancy is at 0 minute, we used to give a dye. Mostly we have to measure the height and the width of the esophagogram. So that denotes whether the patient is having a achalasia cardia or not. Usually the patients the dye get disappeared after 1 minute of the swallow of the dye, and mostly in a healthy individual, 90% of the healthy individual will get the dye get washed off at the end of 5 minutes. So at the end of 5 minutes, if we see the height of the esophagogram is still persist, then we can suggest the patient is most likely having an achalasia cardia. It can also, another added feature is it can also be used as a prognostic tool for the post-surgery patients to look for any recurrence. So esophageal manometry, it is used to study contractile characteristics, basically the motor functions of the esophagus, and it also identify and also classify motility disorders. And also it aids in planning the treatment based on motor abnormalities. The types of esophageal manometry are the conventional and the recent high resolution one. As already discussed well by Dr. Swarup in the physiology topic, the conventional uses 3 to 8 sensors, which is placed around 3 to 5 centimeters apart. And the high resolution manometry uses 36 sensors, which are placed at 1 centimeter apart. So it can predict the motility disorder with a high accuracy. So these are the differences between traditional manometry, where they use sensors at 20 centimeter, 15 centimeter, 10 centimeter from the incisor in the esophagus with a gap of around 5 centimeter. And if you see on the right side, the high resolution manometry involves the 36 pressure sites, which are placed just 1 centimeter apart. So the machine placed over here, it is the high resolution manometry. So difference between conventional and high resolution. The conventional uses water-based catheters. Water-based catheter that acts on the basis of gravity. So it should be given to patient in supine position. So high resolution uses solid state catheters. So we don't want to place the patient in a supine position. Even with a sitting position, we can use with a high resolution manometry. So how the procedure happens? The patient should be in a supine position and then the 30 seconds rest to be given, and patient to be given 10 swallows of 500 ml water each, and 20 seconds rest between each swallow should be done. So basically we will inserting a catheter into one of the nostril, and we have to ask the patient to take sip of water. Every 5 ml should be given at the gap of 20 seconds, and each while the patient swallows the water, we have to insert the catheter simultaneously through the nostril. So esophagotopogram is another modality. Esophagotopogram is nothing but the graphical representation. The x-axis in manometry suggests time. I will show you the graph in the next slide. X-axis in manometry suggests the time, and y-axis in manometry suggests the length of the esophagus. So in normal peristalsis, the graph will always be like a slope. And the color coding, the less pressure or cold areas are denoted by blue or yellow color, and high pressure or hot areas are denoted by red or orange color. So these are the things, and these are the important points. What are the points to look on the graph? So P and D and CDP. These are the 3 points. P point is nothing but the transition between the striated and smooth muscle. We all know esophagus have a component of striated muscle on the upper end. So the transition between the striated muscle and the smooth muscle denotes the P point. So on the D point denotes the transition between lower esophageal sphincter and the stomach. So the CDP point is nothing but the junction between the line drawn from the P and the D point. The junction where it lies, it is the CDP point. I will come into the significance of all those points in the concurrent slides. The parameters, what are the parameters to be analyzed? The parameters to be analyzed are integral resting pressure IRP, and the distal integral latency, and the DCA, distal contractile integral, and the contraction pattern. So what is integral relaxation pressure? It is the lowest average pressure of the esophageal gastric junction for 4 seconds, either contiguous or non-contiguous, within the 10 seconds of relaxation. Normally, it should be less than 15 millimeters of mercury, which means for a food to easily pass through the lower esophageal sphincter, the pressure should be less than 15 millimeters of mercury. And distal contractile integral, it is nothing but the vigor of the esophagus. Is calculated by multiplying average pressure, duration, and length. It involves a segment of length, time, and also pressure. Hence, the unit is millimeter mercury per second per centimeter. And it denotes, DCA is nothing but the calculation between the point from P and D. So how it denotes how forcibly the esophagus is contracting. Interpretation. If the DCA is less than 100, it is ineffective or failed. Weak DCA, we can say if it is more than 100 but less than 450. Now comes the normal range. Normal range is whichever above 450 millimeters of mercury and less than 8,000 millimeters of mercury. So what is more than what if more than 8,000 of millimeters of mercury? It is hypercontractile DCA. We will come into the disease later. The distal latency. Distal contractile latency is defined as duration of interval between the upper esophageal sphincter relaxation and the CDP point, the junction between the P and D. A DL shorter than 4.5 seconds is defined as premature or spastic contraction. Distal latency is nothing but when we are able to swallow something, when the food passes the pharynx. So how vigorous the contraction is used to be. That is the interpretation of distal latency. So if it is less than 4.5 seconds, that means there is a premature or spastic contractions in the esophagus. So interpretation according to Chicago version 3 classification. Chicago version 3 classification is a hierarchical analysis, which means we have to start from one point. The boss of this hierarchical analysis is the lower esophageal sphincter. So disorder of the both body and the lower esophageal sphincter, we can say it can happen in achalasia. If it is happening only in the body, then we can think of diffuse esophageal spasm, nutcracker esophagus. Or if it is happening only in the lower esophageal sphincter, then we can suggest of esophagogastric outflow obstruction, which can also be termed as evolving achalasia. So this is a Chicago version 3. So which we can say, I will interpret this in the current slides. Achalasia, if it is the IRP is more and 100% failed peristalsis or with a spasm, we can say if it is
discussed. Hariprasad.
Yes, sir.
Hariprasad, this is discussed already. You pass on to the next one.
Okay, sir.
They already discussed.
Yes, sir. Yes, sir. So already it has been discussed. If IRP is more than 15 with failed peristalsis or spasm, it's achalasia 1, 2, 3. If it is more than with normal peristalsis, then we can say only lower esophageal junction outflow obstruction. And if IRP is normal with the distal latency less, diffuse esophageal spasm. If IRP normal with more than DCA 8,000, we can say jackhammer esophagus. And what are the types is already been discussed. We have 3 types: classical pan esophageal pressurization, with, and type 3 is the spastic or premature one. So these are the pictures which we already discussed in the physiology part. So management, let's come to the management part. So management involves non-surgical management, which involves the pharmacotherapy, botulinum toxin, pneumatic dilatation, and surgical, as we all know, it's a laparoscopic Heller's myotomy with fundoplication is the gold standard procedure for achalasia cardia right now. And the pharmacotherapy, we can start with isosorbate dinitrate, 5 mg, 15 minutes you can give before each meal, should be given sublingually. Or nifedipine, the calcium channel blocker, we can give 10 to 30 milligram, 45 minutes before meal sublingually. All these things will give only limited response. Basically, these are pharmacotherapies are used in high-risk old age patients in whom the surgery is contraindicated. Side effects involve, as we already know, nitrates and calcium channel blockers both will cause hypotension, dizziness. And the botulinum A toxin is a neurotoxin. It inhibits the release of acetylcholine from nerve terminals. So on decreasing the acetylcholine release, we decrease the pressure of lower esophageal sphincter. And it blocks neurogenic but not the myogenic component of lower esophageal sphincter. Relapse is approximately 50% of patients within 1 year, suitable in high-risk patients. And how to apply? We have to apply it using a endoscopically by a sclerotherapy needle, as I had shown here in the slide. It should be injected just above the spermocalamar junction. And the total dose of 100 units should be divided in 4 and injected in all 4 quadrants at a range of 90 degrees. And another gold standard first line non-surgical therapy is pneumatic dilatation. This is considered to be the first line non-surgical therapy. The principle of it is weakening the LES, lower esophageal sphincter, by tearing its muscle fibers by generating a radial force. It can be endoscopy guided or it can be fluoroscopy radiological guided. Fluoroscopy guided takes longer time and it also involves radiation exposure, and it needs post-procedure upper G endoscopy because all the dilatation procedures have around 4 to 10% rates of perforation chances. So we have to go for a post-procedure upper GI endoscopy to look for mucosal injury or a perforation if we are doing it in a radiological setup. And the types of pneumatic balloon dilators, it involves high compliance, which is high compliance. It is so flexible, which involves Reader Moller, Brown McCarty, and Vigil. Vigil, we will be using it in an endoscopy guided. And low compliance involves the Grutzing Rigiflex dilator, which is the most commonly used dilator in the current setup. Low compliance dilators are rigid, not soft as a high compliance ones. So how it is done? Most commonly used is Rigiflex. We should start the Rigiflex pressure should be started from 30 millimeters of mercury, and we can do a graded dilatation 30 to 35, and we can reach up to 40 millimeters. And 4 to 6 weeks between each dilatation should be given. The gap should be 4 to 6 weeks, and the risk of perforation increases directly proportional to the size of the balloon which we are using. So balloon positioned at the lower esophageal sphincter and inflated with air to forcibly stretch the muscle, and balloon is kept inflated for about 60 seconds till we develop a ischemic ring. We will develop a white colored ischemic ring with average inflation pressure of 10 to 12 pascals, and post-dilatational contrast study done to exclude the esophageal perforation. So this is the Rigiflex. This is shown on the left. This is the Rigiflex pneumatic dilator, the black colored one. You can see the white color ring forming over around the Rigiflex dilator. That is the ischemic junction which satisfies the treatment. And the post-balloon dilatation, LES pressure is relevant to the better remission. We have to measure the post-dilatation LES pressure by a manometry. If there is a decrease in lower esophageal sphincter of more than 50% after pneumatic dilatation, or an absolute end expiratory lower esophageal sphincter pressure of less than 10 millimeters of mercury, are indicative of a clinical success of a pneumatic dilatation. So factors associated with favorable response of pneumatic dilatation. It will show good results in an older age, more than 45-year-old patients, and the results are better in female gender and better in lower esophageal pressure of less than 10 millimeters of mercury following pneumatic dilatation, and the results are better in a narrow esophagus, considering if you are doing in a megaesophagus or a dilated esophagus. And it is very well accomplished by a type 2 pattern on high resolution manometry. Type 2 achalasia cardia have a good results, and the type 3 have the worst prognosis on pneumatic dilatation. And the stents have a limited experience because of chances of migration. We are in achalasia cardia, the stent should be placed in the lower esophageal sphincter. And if you are placing the stents in lower esophageal sphincter, then there is a lot of chances of migration of the stents. So this is limited experience, temporary, self-expanding, fully covered metallic stents should be used. Diameter should be 20 to 30 millimeters. It is used in high-risk patients for whom the surgery is contraindicated. The stent should be removed within 30 days. And the surgery, if all these aspects, the patient is in a position to get operated, the general procedure is to be myotomy. Myotomy, as described by Heller in 1913, initially done with a thoracotomy approach with 2 separate 8 centimeter myotomies at 180 degrees apart. It's an open procedure. And now it has been modified as single myotomy. We are in the open procedure also, we are doing only single myotomy, not 2 separate myotomies. So the gold standard, as I already said, is a laparoscopic Heller's myotomy. The pore placement and exposure should be done, and the dissection of the stomach and hiatus should be done. And then we have to do a myotomy, placed 4 to 5 centimeter onto esophagus, and 2 to 3 centimeters should be onto the stomach also. So these are the things. You can see the mucosa bulging out. The incision had been given. The myotomy had been done. The circular muscle fibers had been cut. We won't cut the longitudinal muscle fibers. We will cut the circular muscle fibers. So these are the you can see the laparoscopic camera and instrument ports, how it had been done. The fundoplication, myotomy followed by a fundoplication should be done, because myotomy may relieve your muscular tension, but patient needs anti-reflex surgery also to prevent reflex. So the general techniques we are not currently practicing Nissen in achalasia cardia. We are practicing the posterior wrap, Taupert wrap, in which in case of associated sliding hernia or inadequate intra-abdominal esophagus, we will do a 180 degree posterior wrap, as it is shown over here. The stomach wraps around in front of the esophagus, in case if it is associated with a sliding hernia. If there is no associated sliding hernia or hiatus hernia, and there is an adequate length of intra-abdominal esophagus. Intra-abdominal esophagus, there should be minimum 1 centimeter of intra-abdominal esophagus should be there. And in case of an achalasia cardia or any motility disorder patient, at least 2 to 3 centimeter of intra-abdominal esophagus should be there. So if there is an adequate intra-abdominal length, then we can go for anterior DORS fundoplication. So post-op care. The post-op care should be the water-soluble esophagogram with iodoxol kind of dye should be given on day 1 to rule out perforation or obstruction. And pureed diet, all mixed diet should be given in a grinded form till 14 days. And the pH testing and manometry should be done every 6 months. And also endoscopic screening for squamous cell carcinoma, because achalasia cardia is associated with squamous cell carcinoma every 5 years, as 8% chance of malignancy over 20 years is seen. So another latest upcoming technique is the perioral endoscopic myotomy. It was described first in 2007 by an Indian origin doctor, Pankaj Parisha, at the John Hopkins in a porcine model, followed by in 2008, Dr. Ino had first described it in humans. So it is nothing but we are introducing a perioral endoscopy. Through that, we are making a myotomy, and through that, we are bulging the mucosa, and we are completing the myotomy without opening, without doing a laparoscopy or open approach. So what are the contraindications for POEM? If the patient is not able to tolerate general anesthesia, because POEM is done under general anesthesia. And relative contraindication, if there is an associated large hiatus hernia, because in POEM we are doing only the myotomy, we are not doing a fundoplication. So in case of a large hiatus hernia, it can increase the risk of GERD. And length of myotomy can be, the biggest advantage is the length of myotomy can be adjusted, because we are doing it in our own vision via endoscopically. So that's a huge advantage when comparing to surgical myotomy. So what are the steps? Endoscopic measurement. We have to look for the upper esophageal sphincter, lower esophageal sphincter to look for the incision. And we have to give a saline lift and mucosectomy. Mucosal incision should always be placed about 3 centimeters above the myotomy plan site. Submucosal tunnel should be created, and we have to do a circular myotomy, and we have to do a mucosotomy closure with a hemostatic clip. So this is the procedure. You can see incision. We are introducing it till the lower esophageal sphincter. We are saline infusion had been done. We are creating a submucosal tunnel. Then we are doing an inner circular muscle myotomy. Then we are closing it with a hemostatic clip. So esophagectomy indications. Esophagectomy is a last resort. If the patient is also associated with a mega esophagus, or there is an undilated reflex-induced stricture, or severe severe dysplasia is there, or the failure of myotomy more than once, then we can go for a esophagectomy indications where we cut a part of esophagus. So basically, this is the latest version, Shackelford's protocol. The patient with achalasia, if it is having a low surgical risk, if it's an younger man, go for laparoscopic myotomy. And if it fails, then we can go for a pneumatic dilatation or repeat myotomy or esophagectomy if myotomy failed. Or if it is a older, or in case of a women, go for a graded pneumatic dilatation. If it gets success, continue with that. If it gets failed, then come into laparoscopic myotomy. If laparoscopic myotomy failed, then go for esophagectomy. For high-risk patients or patients who are not willing to go surgery, go with botulinum toxin, 6 monthly or 4 monthly botulinum toxin. If it is failed, manage with them with the pharmacotherapy, with calcium channel blockers or nitrates. If it gets success, continue, repeat the cycles of botulinum toxin. So thank you for that. Thank you, sir. Hello, sir.
Hello.
Hello, sir. Yes, sir.
You have nicely discussed each and every steps, and you
Yes, sir.
have discussed that how many days you are supposed to do the follow-up after doing the Haller's myotomy, that is laparoscopic Haller's myotomy.
Sir,
Follow-up. As because you have said, so what for you want to do the follow-up, as because
yes,
the and
yes, sir.
By Eckert scoring also you can assess the success of your Haller's laparoscopic Haller's operation, is not it?
Yes, sir. Yes, sir. It's a prognostic tool. Yes, sir. Yes, sir. Post-op surveillance.
Post-op surveillance. So
Yes,
at least 10 years you are supposed to follow up the patient after doing operation. And what purpose? This is for nothing but to see
Yes, sir.
whether the patient develops associated malignancy or not. Certainly you
Yes,
have
sir.
seen the patient was doing well, or occasionally there is the possibility of the recurrence as well. Okay,
Yes, sir.
so that's why we shall have to follow up the patient properly. If there is endoscopy, again, nothing is there. So then we shall
Yes,
have
sir.
to think of, is it a recurrence? What we
Yes,
have
sir.
done, the laparoscopic myotomy, was it inappropriate? That is, we should have
Yes, sir.
given the longer incision. Okay.
Yes, sir. Yes, sir.
So we should consider that points as well.
Yes,
I
sir.
think from my side, it's okay, fine, nice presentation.
Thank you,
Makunda,
sir.
Makunda,
Yes, sir.
any other comment? Hello. 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 Hello.
Yes, yes.
I think that's much.
Yes,
today.
Dr. Bhattacharya.
Yeah.
Yes, sir.
Yes.
Okay.
Thank you.
Thanks. Thanks. Thanks.
Yes, sir. Thank you, sir.